Hello and good evening, everyone. Welcome to this last webinar of the year from the SwissNGM. Today we have a very hot topic. We already had hot discussions behind the scenes about the management of gastroesophageal reflux. We'll start off with medical options that will be presented by Jeanine Wakim, who is a staff gastroenterologist at CHUV in Lausanne. And this will be followed by the surgical options, which will be presented by Yves Borbély, who is a staff surgeon at the University Hospital of Bern in the Inselspital. Some housekeeping rules, please, during the presentations, stay muted. We will do both presentations one after the other, and this will be followed by the Q&A, where you then can ask your questions by raising your hand and then voicing them or writing them in the chat. And without further ado, I think we can dive right in. Jeanine, please.
Hello, everyone. So, in fact, I have been given tonight the hard subject about talking about gastroesophageal reflux disease, but with the frustration about talking of the medications. So, indeed, now in 2025, as for reflux disease, one of the most frequent symptoms causing consultations for primary care physicians, for GIs, we are really suboptimal as for the symptomatic management of these patients. And so before talking about the medical management of GERD, I thought it would be good to start my presentation by touch basing a little bit about pathophysiology, phenotypes, and manifestations, and just talk briefly later about the PPI trial, so the use of PPI for the diagnosis of GERD, and then PPIs as a therapeutic option for GERD, and then to distinguish the refractory symptoms and the re-refractory GERD, and talk a little bit about the PCAPs. So what about the pathophysiology? So GERD is really a complex disease. It's not as easy as it seems. It doesn't only involve or really it's centered around the esophageal exposition to acidity. In fact, GERD involves a lot of motor disturbance in the esophagus, some clearance abnormalities, on top of some abnormalities in the motor function of the stomach also, where gastroparesis is present in a percentage of patients, as well as the acid pocket. So the acid pocket is this region of the stomach in the fundus, which is located below the EGJ, and which had the most acidic environment of the stomach, which is not really well buffered after the meals, and which can extend more proximally in GERD patients. GERD also involves hiatal hernias, so abnormalities in this EGJ barrier or anti-reflux barrier, and Yves will talk about this in detail later on. And the most important thing is that we know more and more that peripheral and central sensitization mechanisms and esophageal hypervigilance play a role not only in the pathophysiology and genesis of GERD, but also its symptoms. So what about the phenotypes of GERD? So GERD can present as an erosive or non-erosive disease. We all know that non-erosive disease is most frequent. It's up to 70% of the patients. And on this spectrum of GERD, we really see on the left where the erosive disease is prevalent that patients have a true pathologic increase in acid exposure in the distal esophagus. Whereas when we move to the right in the NERD, so non-erosive reflux disease, and then farther right, we see that the functional esophageal disorders with the visceral hypersensitivity become more and more predominant. And what is really important is that it was debated for a long time in the literature whether these are really distinct phenotypes or is it a spectrum really of phenotypes. In fact, what we know from the studies is that approximately 10% of patients with NERD or non-erosive disease can progress to mild or moderate erosive disease. And then what is really important in GERD is that symptoms do not predict the phenotype. So what about GERD symptoms? Symptoms can present as typical or atypical. The three typical symptoms are regurgitation, heartburn, and chest pain. And the atypical symptoms can be either GI, like, for example, dysphagia, belching, nausea, or extraesophageal, like ENT or pulmonary symptoms. Now, how do we use PPI? In fact, before talking about the diagnosis or the management of GERD, now still in 2025, PPIs are widely used by GIs, by primary care physicians for the diagnosis of GERD. And this is the PPI trial. So the PPI trial, even in the context of typical GERD symptoms, so regurgitations, heartburn, non-cardiac chest pain, we really see that these patients can respond indeed well to PPI, but the sensitivity and the specificity of this response is low. So based on this PPI trial, it's hard for us, especially specialists, to really rule in or rule out GERD. Why? Because the studies have shown, and we all know it, that the response to PPI can indeed be due to true GERD. It can also be placebo effect, up to 25–30% of cases. It can also be the hypersensitive esophagus, especially the subtype of hypersensitivity to acid. They can also respond to PPI. And we also know that this non-response to PPI can either be due to the absence of GERD, to refractory GERD, or some other etiologies. So when really this PPI trial does not perform so well in typical GERD symptoms, we can all imagine that it really even performs less well in the context of extraesophageal reflux symptoms like ENT or pulmonary symptoms. And the studies have shown that in this category of patients, especially the ones without typical GERD symptoms, in fact, up to 70% of these patients do not really have GERD, and hence the absence of response to PPI. And in the context of extraesophageal symptoms, patients refer to us. When typical GERD symptoms are present, we can try to do, for example, a double dose PPI trial for 12 weeks. But after one PPI failure, studies have shown, also cost-effective studies, that PPI rotation in this context is low yield, and GERD testing is really indicated, as like the recent AGA guidelines. So the PPIs as a treatment of GERD. When we talk about treatment of GERD, it means that the diagnosis of GERD has been objectively made. And we all follow in our clinics or daily practice the Lyon 2.0 consensus. I will not go into details, but now, thanks to Lyon 2.0, it's really well established that we can either diagnose GERD endoscopically with an LA grade B, C, or D, peptic strictures, or Barrett, or non-endoscopically using wireless pH and pH impedance with detailed and well-defined criteria. So GERD is a chronic disease. So now we have established the diagnosis of GERD in a patient. We really need to be realistic because GERD is rarely, in less than 3% of cases, spontaneously has a spontaneous resolution. So we really need to tell patients that it's really a chronic disease. We have to set goals with the patient. So the goals will be to decrease the symptoms frequency, the symptoms intensity, in order to improve the quality of life of patients. So the studies have shown that, especially epidemiological studies, that GERD impacts the quality of life of our patients as much as acute coronary syndrome. And even some studies have shown that it can impact symptoms as much as IBD. And this improvement in the quality, this impairment in the quality of life of patients is independent of the phenotype. And one of also the goals of GERD management is, of course, to reduce the complication rate, especially the Barrett and the peptic strictures. So here in this pyramid, I have put like all the therapeutic options for GERD, starting with lifestyle modifications, medications, and surgery. And nowadays, the approach to treating a GERD patient should be, I think, multidisciplinary. And I will really concentrate my talk in the upcoming slides on the medications. So the medication we use to treat GERD are the acid suppressive drugs. Although we know that these patients with GERD do not necessarily have a high intragastric acidity, but we do not have better treatment, let's be honest. And because intragastric acidity is not really high in GERD patients compared to normal subjects, it may explain in some way that we are unable to cure patients with the use of anti-suppressive drugs. So there are two families of anti-suppressive drugs, the H2 receptor agonists. I will not talk about them because they are not commercialized in Switzerland anymore, and the PPIs. So both of these families of medications act on the parietal cell with different mechanisms. They both reduce the gastric acid secretion and hence the esophageal exposure to acid. We know that PPIs are more effective because they have, in some way, a more prolonged duration of action, but especially they do not have this tachyphylactia phenomenon or tolerance phenomenon. So the PPIs are prodrugs. They really concentrate selectively in the secretory canaliculi of the parietal cell. They do so because they need an acidic environment to be activated in order to bind the proton pumps. And it's worth noting that the PPIs can only bind the active form of this proton pump, which may explain why we tell patients to take them 30 to 45 minutes before meals, because on top of that, they have a short half-life, 1 to 2 hours, and we really want that this postprandial peak of action of the PPI coincides with the active proton pumps after the meal. Usually, we prescribe them in the morning in order to cover the meal time during the day, because meals are usually the triggering factors for symptoms and reflux episodes. And what is worth noting is that when the patient is already on PPI for some time, PPIs can suppress the basal as well as the postprandial gastric acidity. They do not perform that well as an immediate, so on-demand therapy compared to H2 receptor agonists. And so they are the most potent acid inhibitory agent licensed in Switzerland, or rather the only one, because the H2 receptor antagonists are not commercialized anymore and because we do not have PCABs yet. So they are the therapy of choice according to guidelines still worldwide, all guidelines combined. And they are really used in order to relieve symptoms, to heal erosive esophagitis, and to prevent complications like strictures and Barrett. They do not have an etiologic, like an effect on the etiologic mechanism of GERD. As I've said before, they only act as some drugs to reduce the gastric acidity. And we know that PPIs, when we do pH impedance on PPI, we can see that PPIs do not reduce the number of episodes of reflux. They only really change the chemical nature of this reflux wave. So 20 to 30% of typical symptoms of GERD do not respond to PPI because acid is not the only pathogenic etiology in inducing these symptoms. Well, in the literature, there were some studies talking about the equivalence of PPIs. I have put here 2 tables just to show you. I don't know if you really apply them in your clinical practice. I do not. We know that PPIs, most of them are metabolized primarily by the CYP2C19 in the liver. We also know that the pharmacokinetics are different. The CYP2C19 has some genotypic variation among individuals, which can explain the different enzymatic activity. So there are some studies which have shown that patients can be ultra-rapid metabolizers. And indeed, in this category of patients, when we give, for example, low-dose PPI or standard-dose PPI, the efficacy will not be optimal. And on the other spectrum of the genotypic variation, there is also the poor metabolizers who, under or when taking normal or low-dose PPIs, they can have high PPI exposure and sometimes adverse effects. It is really debated. And so, like, PPIs and their action depend on the phenotype of GERD, and this is why I've talked before about phenotypes. Studies have shown that the efficacy of PPI is better in the erosive reflux disease than in non-erosive reflux disease, because they are really drugs which perform better on the mucosal healing compared to symptom control. And even when they heal erosive esophagitis, we see it on a daily basis that patients can still present symptoms, although the erosive esophagitis have healed. And the efficacy of PPI is well demonstrated for heartburn, but they really do not perform good in the regurgitation subtype of patients. And we know that when we increase the dosage of PPI, we only have a 20 to 30% symptomatic gain. And the dose response effect is also more demonstrated in the erosive subgroup of patients compared to the non-erosive subgroup. And we know that when we double the dose of PPI, we inhibit more the gastric acidity, and hence we increase the chances or the probability of healing the erosive esophagitis. So it's also worth mentioning that PPIs perform well as a maintenance therapy in erosive esophagitis, especially the severe form, because when we stop PPI in almost all of the patients, there will be within 1 year, recurrence of erosive esophagitis. So in the subgroup of patients who present with extraesophageal symptoms, PPI really do not perform well. With patients with ENT symptoms, with pulmonary symptoms, PPIs are not really good, because we know that in this category of patients, there is also regurgitation, there is also microinhalation, and PPI will not correct the barrier, which is defective most of the time. And the side effects of PPI are also debated. In fact, we do not have good long-term prospective studies. Most of the studies which have talked about some maybe side effects linked to PPI are population-based studies. These side effects are really at best modest. They are dementia, chronic kidney disease, fractures, SIBO, C. diff, colitis, pneumonia, spontaneous bacterial peritonitis in cirrhotics. But maybe we should stop as clinicians and ask ourselves that, okay, we do not know if really on the long run PPI cause side effects or no. We should really ask ourselves, are we maybe not contributing to some side effects? Because some studies have shown that even when we test these patients and we find that there is no GERD, we are really not performing so good in instructing patients to stop PPI and to document in our reports the need to stop the PPIs. And one of the few prospective studies which tried to see if PPIs really have some side effects is the COMPASS sub-study trial. So the COMPASS trial is really a New England published study in 2019, which with the aim evaluating like acute coronary symptoms, the use of Eliquis, and the use of PPI to prevent GI hemorrhage. And then the sub-study trial was conducted in a multicentric way in a prospective trial for 3 years. It included 18,000 participants, and the goal was to try to see if the patients who were receiving pantoprazole compared to placebo at baseline will develop any of these potential side effects which are described in the literature. And this study has found that none of these side effects was linked to the use, was found in a statistically significant way in the pantoprazole group compared to the placebo group. They have only seen some trend or increased risk of non-Clostridium enteric infections. But again, here in this group of patients, the number needed to harm was really high, I think around 300 patients, and so the clinical risk is really low. So what about the other agents we have to treat GERD? So there are the mucosal protective compounds. These are basic agents neutralizing acidity. They only reduce symptoms of GERD, although some studies have shown that when they are used as an add-on to PPI, especially the alginate, they can really control symptoms, especially the heartburn, better than PPI. There is also the sucral fat, which is an aluminum salt, and they both act, the alginate and the sucral fat, as protective, protective agents to the mucosal barrier. So they are only like mechanical therapies or mechanical devices which will protect this mucosa from the ongoing reflux. And some other adds-on which we can use with the PPIs are the prokinetics, the baclofen, and the antidepressants. And let's say the studies are not really frequent using these agents, and the studies done, for example, with prokinetics are really not optimistic at all. They can only increase the symptomatic control in a very modest or even mild way. They have a lot of adverse events. I don't know if you have prescribed baclofen in any young patient who needs to concentrate at work, who needs to drive. In fact, the dizziness, the drowsiness, the somnolence is really a prevalent and frequent adverse event. And the antidepressants can be used, I would say, maybe in this subgroup of patients who have some hypersensitivity. Now, in fact, when we talk about the use of PPI in the management of GERD, I think definitions are really important, especially for us GIs. So we should really now be able to distinguish the refractory heartburn or refractory symptoms and the refractory GERD. So patients with refractory symptoms are patients who have heartburn, which is not responding to a double dose of PPI over 12 weeks. Also here, the definitions and expert opinions are really different, but this is the commonly used definition. And in this subgroup of patients, the symptoms may not be caused by GERD. On the contrary, when patients have true refractory GERD, we know that the symptoms are caused by an ongoing reflux of gastric contents, which is not controlled by this double dose PPI over 12 weeks. And here, really, the symptoms are caused by an inadequate management of the reflux disease. Why it's important to really differentiate this subgroup of patients? Because we know that in this category of patients who have symptoms refractory to PPI, it's really a huge umbrella of diseases, let's say, or phenotypes of GERD, because in this umbrella, we can find patients who really have true non-erosive reflux disease, but we also can find patients who have a hypersensitive esophagus, whether it be to acid or non-acid, and also some functional heartburn patients where we know that the PPIs will not be at all efficacious. And in our daily practice, we all see it that up to 40% of patients, if not more, honestly, have PPI refractory symptoms, especially these nurse patients, the patients with atypical reflux symptoms. And like the most frequent cause of symptomatic non-response to PPI is the absence of GERD, because PPI are really potent gastric acidity inhibitors. And so in this subgroup of patients with symptoms refractory to PPI, up to 60% do not have real reflux. They have either functional heartburn, rumination, hypersensitive esophagus. And one of the other causes which may explain symptoms refractory to PPI may be the suboptimal compliance, the improper dosing of PPI, because some studies have really showed that after 6 months, when we give this patient the prescription for PPI, only 1/4 of these patients will continue to take the PPI as they should. I've also talked about some genotypic variation in the metabolism of PPI. Maybe it can explain why some patients are more refractory to PPIs than others. And it's only in 10% of patients that we find true refractory GERD. And in this subgroup of patients, when we So now that we have a proven refractory GERD according to Lyon 2.0 consensus, what can we do? In fact, we can try to optimize the PPI treatment. We can really assess the compliance with the patient. We can really make sure our patient is implementing the minimum of the lifestyle modifications, like some weight control, some dietary modifications, like elevation of the head of the bed, like increasing the interval between the meals and the supine position, trying to sleep, for example, on a wedge cushion during the night. We also need to really, in detail, go with the patient through the PPI way of taking the PPI, like really make sure that he has the proper dosing, the proper use of PPI, that he should take it really on an empty stomach, 30 to 45 minutes before a meal. We can try also, for example, to split or spread the PPI dose morning and evening. If, for example, symptoms are really bothersome at night, We can, in some countries, not in Switzerland, add the H2 receptor antagonist. And in Switzerland, we can really try sucralfate, alginate-based therapies. And I think most of these patients have some part of hypersensitivity, some added anxiety, hypervigilance, and maybe some psychological comorbidities that we really need to address. So I will quickly talk about the vonoprazan. I don't know if you have all seen the study of Lane in gastroenterology in 2023, which have led in the US to the FDA approval of the use of vonoprazan for the healing and the maintenance of healing of erosive esophagitis. So in this study, vonoprazan has been superior to lansoprazole in the healing and the maintenance of healing in erosive esophagitis. So what is vonoprazan? So vonoprazan is like a PCAB, a potassium channel acid. Sorry, it's like a drug which will compete with potassium on its binding site on the proton pumps. It has a selective and a reversible inhibition of the proton pumps in a dose-dependent manner. The big advantage over PPI is that this drug will go and bind with both the active and inactive proton pumps. So in fact, it will lead to an easier administration for patients, because it will not, it's not, so taking it on an empty stomach is not needed. And the 30 to 45 minutes dosage before meals is not important, because it can be taken at any time of the day, because it acts on this on these inactive proton pumps. So when this drug will act on these inactive proton pumps, you can imagine that it has even a more potent inhibition effect of on the gastric acid secretion. And then in this study, which is not a long-term study, the study published in Gastroenterology, some people were asking, what about the side effects and the risk of neuroendocrine tumors, for example, and metaplasia? And what went out from this study, as well as the studies from Asia, which have used vonoprazan as well as other PCABs. In fact, we have seen that it's more effective than PPI in Los Angeles C and D esophagitis. In fact, we did not see a significant improvement in the control of the heartburn in this category of patients. And in fact, maybe this is a little bit expected and not a surprise, because we know that when we double the PPI dose, we arrive to a maximum of a percentage of symptom relief that we can provide for these patients, because we know that the genesis of these symptoms related to the reflux are not solely due to the acid reflux, but also to all of these pathophysiological mechanisms which are really there and cause the GERD. So the take-home messages that I would really like to stress on are that GERD is not like one pathology. GERD is a family of syndromes. It has a complex matrix of contributing pathophysiology. PPIs are the first choice therapies, still the first choice in all the guidelines across the world, but we know they only act on one of the multiple etiological components in the GERD pathogenesis. And whenever we go to the hypersensitivity on the spectrum, on the end spectrum, we know that they will not be as efficacious. And we know that in erosive esophagitis, when we increase the dosing of PPI, we increase the chances of healing the esophagitis. Sadly, this is highly questionable in the management of the symptoms secondary to reflux. And I think that the concept of one size fits all to therapeutics do not apply anymore in 2025. And we really need to adopt like a personalized management approach to all our GERD patients by recognizing that really anxiety, hypervigilance, and hypersensitivity play a central role in the genesis of symptoms. Thanks a lot.
Thank you very much, Jeanine, for this great overview over the medical aspects of treating our GERD patients. If you could unshare your screen so that Yves can talk to us about the surgical aspects, and that will be followed then by the discussion. I don't know if I can make you unshare. No.
Yeah, I don't know why I'm clicking on it, but it's so weird. Okay, Just 1 second, I'm sorry. Is it working now?
Now you're gone, exactly. And I think the stage is free for
Sorry.
Yves.
Good. I hope you can see everything. Yeah, thanks a lot. So let's go over to the second part, surgical options. Wait a second. Yeah, so I'm a surgeon. Despite all that, I do not claim knowing the truth about everything. Yet I'm a friend of novel procedures, and I truly think this has to be performed in studies, and we need objective evaluation. Otherwise, we're doomed. And I'll come to this topic back later in the talk. I see a lot of procedures done kind of somehow, and we truly need quality control, and this lacked for quite some time. And is it really, for me, it's a huge thing that we really do see our results. And having said so, I'm not a friend of or actually, even despite recent developments in our societies, I truly think surgery and gastroenterology are friends and not opponents. Another thing, GERD, as we've heard, is not the same as hiatal hernia. Despite them, there might be overlapping symptoms. I'm talking only about GERD today. So what I'm talking about will be surgical options. What kind of options are we having? Will there be a future for surgery and in treatment of GERD? And the next thing will be visceral motility disorders and surgery. And also I try to answer a question, why or what's the connection between this guy and one of our famous surgeons. So a short review of surgical concept. I'm really hesitant to see all those newer interventional techniques rising up and promising good success. So I'm not really a friend of this, and I try to give you an insight into a surgeon's mind and why we do not really think that surgery is a need. And otherwise, I mean, I'm really happy to be on the beach, but truly, I think there's some work to be done. So what is the ideal anti-reflux procedure? It restores the ileus barrier function, preserves normal physiology, so especially swallow, belch, vomit. It provides consistent outcomes. It's standardized, it's minimally invasive, and it's easily reversible. And thinking about this, we haven't really reached optimal solutions. Now, tour d'horizon about the possible procedures we're having. So Rudolf Nissen, truly one of the most famous surgeons, actually operated on Einstein as well. Sadly enough, he died 3 months afterwards. Still, it wasn't for an anti-reflux procedure, it was for an aortic aneurysm, but he introduced the concept of the Nissen fundoplication, this kind of gastric plication, 360 degrees in 56 in 5 cases, a little bit different than nowadays. So we have other traditional methods. So on the left, the traditional 360 wrap. Then we have this door, which is anterior, and we have a toupee, which is only 270 degrees. We call them traditional. I will go into more novel procedures afterwards. There's a huge discussion about, should we perform partial? Should we perform total fundoplication? This also comes with a mindset of manometry or esophageal motility and kind of a tailored concept, which I will go into afterwards. Just to be really, really true, I mean, there is a difference between the real world and studies. So we say, I mean, just do the plication you're used to do, because there's so much symmetry, so much kind of seeing involved, that it's best to just do one procedure good than like 100 procedures not that good. And all the randomized controls trials have some failures. And on the left, you see like one of the famous trials, and they published these pictures that something I would never accept. So this is how a partial, like a Nissen publication should look like, and not like this. So, and if you have pictures like this, you cannot use these studies. Still, there are a lot of good surgeons out there who perform both applications. Just to summarize, in the end, it's kind of the same. Short term, less dysphagia. Long term, a better control of GERD. When I say GERD, I say typical symptoms and not atypical symptoms. Still, there are other procedures, and actually one of the newest procedures is also based on this Lochta-Jacob hydroplasty, which was done ways before the Nissen procedure. Again, we know laparoscopic anti-reflux surgery is effective, even a little bit better than PPIs. We can debate on that. However, it comes with side effects. So we have dysphagia, bloating, and diarrhea in a lot of patients, around a third in Nissen fundoplication, and this really is not what we want. Further, GERD is not GERD has different aspects. We heard this before, and we see more and more different aspects as we have newer diagnostic measures. We have a different kind of spectrum of indication and patients, mostly obesity and motility disorders, and we have more and more patients with altered anatomy, which forces us to bring new solutions to different questions. As I said before, we have a lot of options, but in the end, it's Toupet and Nissen, like the traditional ones. We have anti-reflux devices, highly debated. I will quickly go through them just to give you better knowledge. What we in the end want is a patient-based or patient-centered treatment that is safe, that does not have a lot of side effects, but you'll see it's not that easy. So angle cheek prosthesis, not done anymore. You see this constringent ring around the esophagus. And I think this is the last one on the world that I had the chance to take out. Then we have the links, so it's magnetic sphincter augmentation with the idea that you can swallow, you can belch, but otherwise there is some pressure, I would say, on the LES. With very good results in the end, in studies, again, in studies. So 5-year follow-up, PPI use 15%, dysphagia 6%. However, real life looks a little bit different. So the post-op dysphagia really is the Achilles heel of this procedure. This would address differently in putting in the diameter like larger, so putting more beads, more 15 to 17 than 14. So the dysphagia rate were reduced. Look at the dysphagia rate, 60% versus 30%. In my opinion, still enough. Still a lot. And short-term dysphagia, which is 3 months, is up to 83%. So for me, this really is not a suitable procedure. And we see ways and ways less of these implants being performed. We have another thing. It's the neuromodulation of an esophagus. It's the endostim. It's kind of it's not really clear what the mechanism is. It's kind of a vagal stimulation, kind of a neuromodulatory LES device, which proved good results. 3-year persistent low acid exposure when you take this, when you stimulate and then do not stimulate anymore. Actually, the pH, esophageal pH goes up, and then you again give your stimulation, it goes down. So there seems to be an effect in there. And it's also usable for other things. So ineffective motility, post-bariatric, they don't have a fundus. However, they did a multi-center randomized double-blind sham control trial which we also were part in. And this really was a disaster. So they didn't see any difference in the results all in all. And I actually had to close shop. It has to be said that they reinvented the endostim and brought it to the market, and it probably will come next year. And they passed now the FDA regulations because somehow the data was kind of flawed, but so far we don't have any more information. Then we have the reflux stop, which is kind of the newest device. The thing there is it consists of a lateral esophageal gastrostomy, and then you implant this reflux stop, this silicon ball, which is around 2 centimeters. Which results in that the whole Elias package will stay below the diaphragm. And in case if there's penetration of this device into the stomach, those 5 parts will go away by means of passage. And this is how it looks like from the inside. So you see this. Yeah, implant here. The whole esophageal diameter is free, and there is only this side that's affected. That's the whole thinking in this reconstruction. Again, here, I mean, it's still. I mean, we started 8 years ago, and now we have a lot better follow up than this study I did like 3 years ago. It really works, but it's not for everybody. I think it's a device or actually a procedure you can use, in my opinion, for patients that are bloated, that do not have a lot of hiatal hernia, or like the hiatal hernia size is kind of small, and they're not willing to undergo a traditional procedure. But I wouldn't really implant it in everybody. What about safety of this procedure? Because as we heard, foreign material around the esophagus really is a problem. Angle-shake links here a little bit different. I mean, the safety profile so far is okay. I mean, hiatal hernia recurrence in 1% is really okay. Bleeding, device dislocation, stomach ulcer, and then we have early penetration in 4 patients. So far it's okay. I mean, in 602 patients with a follow-up of 1 year, it's okay. But again, it's 1 year. We need 10-20 year data to really be sure. Coming back to the surgical steps in anti-reflux surgery, or why I think the type of anti-reflux procedure is not that important. It's way, in my opinion, we have factors that have to be addressed that are way more important, and no one talks about it. So obviously we'll start with the functional evaluation. I think that's key, even though it's not done 100%. Then we have to prepare and dissect the hernia sac. We have to allow for esophageal length, intra-abdominal length. Then there's hydroplasty that has to be done, and then there's the anti-reflux procedure. And why I'm telling you this is, it will be. We were talking that these were the discussions before the meeting. So I'm a little bit hesitant in really, welcoming the newer interventional methods, because you'll see these steps. They were learned over decades. The importance of this is really not debatable, and they're actually all omitted in those new interventional techniques. Still, we're not really sure what kind of what's the importance of maybe hydroplasty and anti-reflux procedure. There are 2 really big thinking schools. So on the left we have Nissen, who says, okay, fundoplication, doesn't matter where, can be up in the thorax, no problem, it will help. And on the other hand, we have Ellison, who says, okay, hydroplasty is the key, forget about fundoplication. And in the end, both are not right. Still, we have, and this is the Meester's data, we know that the structure on the hiatus plays a role. So if we have enough length of intra-abdominal esophagus, the LES can build up more pressure, or actually needs ways with more pressure with a longer sphincter in the abdomen to open. And if in presence of hiatal hernia, meaning distensibility of the gastroesophageal junction, the distensibility is ways bigger in hiatal hernia cases than in normal patients. So these all are signs that it is really important to close a hiatal hernia. And we also have clinical data. I mean, we've talked about endostim. Endostim in the end is hydroplasty plus implanting 2 electrodes and nothing more. And we have seen in these data that hernia below 2 centimeters have the same outcome as repaired hernias. However, if you have a hernia more than 2 centimeters that's not repaired, the outcomes are ways worse. And the same is in the links, as a magnetic sphincter augmentation, where you really see a difference between hydroplasty and no hydroplasty. So if you look at if you do an intraoperative flip, you see around, and you see here the initial, then if you repair the hernia, obviously this distensibility will go up. Then you perform crural closure, and this is the difference between anti-reflux procedure and crural closure. So you see it's not that much. This all led to a new definition of the esophagogastric junction. It's not only, so it's actually 3 components, like the crural, the physiological, mechanical part, hiatal hernia, as I said, the mechanical part, and then also physiology. I mean, you take into account the different muscles, and in this, you try to find the best procedure. As I said before, we have lessons were learned over decades on patients, and I truly do not think that we should forget those lessons. So I truly think hiatal hernia play a role, even if they're less than 2 centimeters. Question mark, how to define hiatal hernias. And this simply cannot be addressed by endoscopic measures. Same with the crural repair. So this is why I'm not really a friend of interventional techniques so far. Maybe I'm completely wrong, but I truly think my job won't be. I will still will be, despite AI, despite interventions, I will still be working in 20 years. Now, just the last point, tailored concept. It's such a good idea. So the thing is, can we avoid postoperative dysphagia by tailoring a wrap or actually a procedure according to esophageal motility? And I mean, obviously, everybody says yes. I mean, good motility, do a Nissen. Bad motility, as we see here, or actually worse motility, rather do a toupe or a reflux stop, something like this. Makes sense? So far, there is no study that really has proven that really actually, even though it makes sense that really in clinical setting works. We have patients with esophageal amotility. We perform Nissen on them, and it works without any problems. Obviously, it's not something we would do just like this, but yeah. So the only predictor for post-op dysphagia is pre-op dysphagia. And this is actually known for more than 20, 30 years. Still, it's not the thinking, you cannot abolish the thinking. And newer studies show now, if you have a contraction reserve proven by multiple rapid swallows, this might be a hint that still there might be a role for the Taylor concept. But we have new measures. We have the flip. And with the flip, and I truly think this will be the future, that we do intraoperative flip and tailor our procedure or our rep according to the values that the post-op dysphagia and also the bloating will be ways better. And as we can see here, the flips initially, then again hernia reduction, so we see more disability, and then the crural repair actually plays the most part, so it's around 80% crural repair, and then maybe the rest 20% type of fundoplication. And I think this really should be one take-home message. In my opinion, hiatal hernia repair, the just classic surgical steps are ways more important than type of fundoplication, even though obviously it's not as sexy to talk about hiatal hernia repair than type of fundoplication. To conclude, I think surgical procedures can help in a lot of GERD influencing factors, be it motility, be it hiatal hernia, be it gastric motility. But again, as we heard before, it's a together. It's not like surgery is the only option. No, it might be one option that we can choose for the patient. And with that, I'm finished. Thanks a lot for your attention.
Thank you so much, Yves, for that overview. We have 10 to 15 minutes left for discussion, questions, and answers. Thanks to both speakers for those excellent presentations. Please write your questions in the chat or raise your hand, and then we'll open your mic. While we wait for the first questions, I might ask my first question to Jeanine. I always have this discussion about the timing of PPI, and I always ask my patients when they take it. And what I find is that some patients, they take it every morning, but they don't actually eat breakfast. What is your management in those? Do you recommend them? Because in all the studies that I have read, it's clearly defined as the first meal of the day and not necessarily as the morning dose. How do you manage that in your practice?
Yeah, exactly. As I was saying before, I think like it's really one of the major causes of why symptoms may not respond in an optimal manner to PPI. And I think that in this category of patients, maybe they should take it before lunch or before bedtime, I mean, before the evening meal, because really it's very crucial for PPIs to act, to give their maximum effect on symptoms or on proton pumps, that they should be taken on an empty stomach, but meal should follow. So really, they should like really manage it according to meals. Yeah.
Thank you. Then maybe also in the interim, Yves, you mentioned that the tailored fundoplication is some logical concept we have, and you also mentioned that the lack of reserve on the manometry when we look at multiple rapid swallows is a predictor of post-operative dysphagia. When you as a surgeon, you get the patient admitted to you for anti-reflux surgery, and you know that they have no peristaltic reserve on manometry, does that change your approach or not really?
Yeah. So I'm guilty, even though I'm saying it's not proven to be a concept that works. I still, I'm hesitant to really perform like a total fundoplication on a patient with really bad motility. Really.
I think if you can do it, because like honestly, as you said, like honestly, the studies with the multiple rapid swallows are really lacking. Quality of data is not that good. And I really think we should not prevent patients from having a fundo, whether it be a Nissen or no, or like a crural closure or repair of with fundo, without fundo. I think the multiple rapid swallows are really not by far not the optimal test for predicting postoperative dysphagia. Doing manos every day, seeing these patients, I don't think it's a really good predictor for postoperative dysphagia.
Again, you're right. Still, if you have one patient where it doesn't work, you're doomed, yourself because
Yeah,
you're seeing them the whole time, and everybody else thinks, well, what kind of idiot does on this? No? What I really would plead for is like a complete evaluation, also maybe do gastric emptying studies and just see the whole picture before like a team, maybe interdisciplinary team, will decides on the best way to go. That's how we do it.
exactly.
Again, I mean, you cannot win the whole time. That's a little bit of a problem with this kind of surgery. Yeah.
Exactly. We also do it this way. I mean, some patients with peristalsis have had some fundos and they are performing well. And it's really a multidisciplinary approach when it comes to surgery with impaired motility.
Yeah. I mean, same after. Oh, excuse me. Yeah.
Quick question, Radu. Radu is here.
Oh, yeah.
Yves, thank you very much. Sorry, I came a little bit late. You mentioned in the end, Yves, that you use end of lip to tailor your frontal application. When you use the end of lip intraoperatively, what are you aiming for?
So we're starting to use. I really have to be
okay.
because logistically it's not that easy to be honest. Yeah.
Where do you find the difficulties? What's difficult? Where do you find it difficult?
In the end, it's. I mean, we have like 1-2 guys doing functional evaluation here, and like going back and forth between the OR is not that easy. And to be really on time, because we really have some time constraints in the OR. So this actually is the most thing. But when we do it, it's. I mean, we do not have value so far. We do not have objective values. So this is. But I think. I mean, this in 2, 3, 5 years, this will be over, and I truly think this can add some worth to the whole thing. In terms of like how close, I mean, the closure of the hydroplasty, stuff like this really, in my opinion, plays a role. And so far, everybody thinks he knows how to do it. No, it's not objective. It's just subjective, some swing. And if we take like this variable out of the equation, this might calm a lot.
Yeah. No, that's what I'm trying sort of make the point of this, sort of to really try to bring some standardization in the things, and that sort of one thing is knowing what you're aiming for and define a target. You may be wrong with it. That's now nobody's. I mean, since there is something new and no one knows exactly what to do. But I was wondering, sort of, do you try to normalize the sensibility, because most of these patients will have a really sensibility that's below the normality.
Yeah. Because I mean, there's one study looking 5 years after like intraoperative flip and how it's working out. So if you're aiming for too low, it's not good. So the recurrence is there, will be there. So I mean, you will have, despite I'd say tailoring with flip, you will have some kind of dysphagia for like 6 months something, and then it's gonna get better.
That's another important point is that you're hey Daniel here, that you're mentioning now, because I mean, patients 2 months after surgery, they get impatient, right? They have some dysphagia, and even us as gastroenterologists, we tell them, wait, this is early. Number one, you've had a loose esophagus all your life, or in the last years for sure. So your body needs to get used to it. Number one, and second, there is an adaptation period which takes up to 6 months in our clinic. I don't know how you handle that.
Yeah, same here. I truly think the role of gastric emptying cannot be underestimated. There's definitely a change after fund application in that, which is not well understood so far. Yeah. But again, I mean, in the end, you have to be patient, and to really see. But after 6, I mean, if someone really has dysphagia after 6 months, I'm not happy. Actually, and I mean, even after 3 months, I'm quite aggressive in do a real functional evaluation. But 3 months, I think we should wait.
Are you still implanting links?
No, we never did links.
I asked him the same question.
Yeah. Okay.
No, but I mean, I'm in this reflux stop versus fund application. It's a prospective randomized study. I'm in there. This I'm doing, but again, I mean, although I'm a huge friend of those novel techniques. However, really only in studies.
Yeah, I think that's
truly
key.
think is key.
And it took some time to start a randomized controlled trial, right? I mean, this is just starting, correct? The trial
Yeah,
that
it's
you're
just
mentioning.
it's starting now. It's starting now. Yeah, it took some time, and it can break a company if it doesn't really. I mean, we've seen it with Endostim. If it doesn't work, you're gone. Yeah.
Yes. I thought Endostim was coming back in the US. Was this?
It is. It actually they passed FDA the FDA ruling. The thing is, they could show that for the I mean, I'm a little bit inside the whole Endostim because I'm really interested in it. So for the FDA, only data from the US is actually gonna count. So the whole European data is out, and in the US they really could show that that's an advantage, significantly better with than without Endostim. But this is why they were granted. And it's coming back from Europe as well, but this is gonna take a year or two. Yeah.
Okay.
But maybe in Switzerland, I don't know about the newest regulations. Maybe you're closer to Trump than me, but we'll probably
I hope not.
take it over. Yeah, exactly.
Almost an insult, Yves.
Yeah.
So, Jeanine, are you looking forward to the PCAPs?
Yes, but I don't know when they will be commercialized. Honestly, I think they have some role in erosive esophagitis, but I'm not so optimistic for the non-erosive phenotype. Do you think they will perform better than PPI?
Yeah, I'm not
I
so
don't
sure
think
either,
so,
because
honestly.
in a number of non-erosive
Yeah.
patients, I think we're not really treating reflux, but we treat something else.
Exactly.
And
Yeah.
they may or may not be better in those patients. I really look forward to the PCAPs for my difficult esophagitis patients, difficult ulcers, also the anastomotic ulcerations, which usually are mostly hypoxia driven, but still they profit from antacid treatment. And thirdly, I most look forward to it in combination with amoxicillin for HP treatment, because they've shown nicely that the potency of the acid inhibition is the vital factor if you want to treat HP. And then we can stop using triple and quadruple regimens, at least as first-line therapy, and think about going to just a very, very effective antacid treatment plus single-dose antibiotics. So I really look forward to them coming, and I hope. What I heard is that it's coming in Europe end of next year, so probably I mean, this is don't be mad if this is not true, but this is what I heard. And then I guess for Switzerland would be more like beginning of 2027. So I hope they will be coming, but yeah, I'm waiting as well.
If there are no further questions,
apparently you can get them. Apparently you can get them in France. That's what I heard from a colleague. That apparently you can get them in France. You can get the vonoprazan.
Yes, that's right. You
already.
Can get them around. It's not so difficult. You can get them in the UK, and you can get them via the international pharmacy. And I think I haven't checked the price, but I didn't see that people were complaining about it so much about the price. So yes, that's a good comment, Radu, that we're able to order them from out of country.
Yes. Mm-hmm.
Great. So if there's no further questions or remarks, I think we can conclude more or less on time this last webinar of our series. Thank you so much, Yves and Jeanine, for your excellent talks. Please stay tuned in your email where you've received all the information on this webinar about our program for 2026, which is being created as we speak. We have next webinars planned, and we'll keep you updated on those activities. And in the a nice evening. It's already time to wish you a nice holiday season, and see you next year again for the next webinar season. Take care, everyone.
I can see you. Bye. Thank you.
Thank you very much
Bye.
to everyone.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.